Hey, Ralph, I am so excited for today's episode. What about you?
I am as well, Yvonne, because I know I'm going to learn a couple of things. I always enjoy our conversations with this guest or guests, and I'm really looking forward to it because I know I'm going to pick up a couple of things here. I'm going to be better off for it.
Well, this is a really deeper conversation about some really specific stuff in workers' compensation. Today, we've got Dr. Tomer Anbar and we've got Dr. Ramsey Ali from the Institutes of Health, and that's where I work on a daily basis, and I enjoy working there so much. And you're right, I learn every day working there. Every time I get to dive into a topic, I learn and I love it. So we are going to talk today about substance use and when it is industrial in the workers' compensation system. So fascinating topic. Let's get to it, shall we?
Let's do it.
Hello, Rafael. How are you today?
I am doing great, Yvonne. How about you? How's it going in your neck of the woods?
If it were any more fantastic, I really don't know what I would do.
Okay, I'm going to hold you to that.
I am so excited for our guests. We have two doctors with us today, Dr. Tomer Anbar. Hello, Dr. Anbar. And Dr. Ramsey Ali.
Hello.
Thank you so much for joining us today. How are you both?
Listen, if I were to answer that question, it's always a blast seeing the two of you. So, I mean, how much better can you get than that?
Well, thank you.
Yeah, you're very kind. Thank you.
Yeah, thank you so much. So today we're going to talk about a topic that we don't really hear much about in the workers' compensation industry. But before we start, I'd like for each of you, so I'm going to start with you, Dr. Anbar. For listeners that may not know who you are, please explain your role in the workers' compensation ecosystem.
So I'd say in general, for the past 40 years, I've focused on epidemics and what I call man-made epidemics. And when we look at the ecosystem in work comp, that's really significant because main drivers of the work comp system are man-made epidemics, which is chronic pain, brain injury, and complex PTSD, and associated substance abuse. And so that's why I think it's such an exciting topic to speak about, because it gives us the opportunity to change the paradigm, to understand that these are reversible epidemics. And thank you for shining the light on this.
You are most welcome. So just to add a little bit of another layer there, you are also the founder of Institutes of Health, where I work. That is my day job, and for Dr. Ali as well. So thank you for doing what you do. It's amazing.
Well, look, we're really excited and passionate about what we do because we have a research institute, we have a training institute, we lecture and generate our training across the country. But it's always a blast for us to be able to interact like this and to demonstrate how exciting the work comp space is altogether. And I hope we get to touch on that, because the two of you actually always seem to be able to touch on the fact that we love what we do. We're passionate about what we do, and we love this space.
We do. Thank you for saying that. And we are so happy that you mentioned that, because that's definitely what our podcast is about, sharing the enthusiasm, the passion that we all have for this industry, and hoping that we'll have more young professionals want to join the industry. So with that, Dr. Ali, give a little introduction of yourself. What is your role at Institutes of Health?
Sure. And I appreciate that. And to go after Dr. Anbar, I mean, there is just a lot there. He is one of the masters of the workers' comp system. And so mine's not nearly quite as impressive, but what I can say is I've been working in workers' comp since about 2022. And so I came from the VA systems prior to that. And so it was my first interaction in more of a med-legal system and getting more familiar with these injuries. And as Dr. Anbar alluded to, the reversible epidemic conditions. And so my role specifically is I work as the clinical director of the PTSD intensive outpatient program, working with both civilians and first responders. And in that role, when people come for a workers' comp or industrial related injury, the pathway to get to where I am in the IOP, the intensive outpatient program, typically starts off as what we call unimodal services. So it's an opportunity for that individual patient to try to resolve that issue at an outpatient level of care. And the majority of patients do resolve at the outpatient level of care once a week with a provider, whether it be a psychiatrist, a behavioral medicine specialist. But if that 20% or so needs a higher level of care, that's where my role is to manage the intensive outpatient program and getting people the care they need for PTSD, and really substance use is a vital part of that if needed for a lot of the patients. And so my role is to get them back to work functioning after the IOP and get them on their way. And it's been a very, very successful program. And I think Institutes of Health does a tremendous and phenomenal job on the level of care and how that's completed. It's really a unique perspective that no one that I know of takes that approach to integrated care.
Thank you both. So yeah, there are so many things we could talk about today with my knowledge of all that I've learned after joining Institutes of Health. But today we're going to focus in specifically on substance use, addiction, and detox and recovery. These are not things that we typically hear in the workers' compensation space. So Dr. Anbar, I'm going to come back to you and ask you to explain why should we and why should other workers' compensation professionals be talking or thinking about these types of things in the work comp ecosystem?
I think it's a great opportunity to frame the whole topic the way you just brought it up. And I just like to take a minute because we have a lot of new people in the work comp space. And hopefully we're going to get a lot more. By the way, if people are interested in reading about some of the things we do in this latest issue of Public Risk Magazine, it further talks about the cover story about some we're going to be discussing here. But what's important to remember is that the work comp system grew out of one of the most morally and ethically grounded and economically pragmatic innovation of the industrial era. This is a mind-boggling thing, the work comp system. And what evolved was a no-fault insurance compact. And what that meant, and what it's referred to, is the grand bargain. And when we refer to the grand bargain, what we're talking about is that injured workers gave up the uncertainty of litigation in exchange for timely medical care and wage replacement. In turn, employers gained predictability, workforce stability, and insulation from catastrophic exposure. So what better system can you have in place? It is the ultimate win-win situation. Somebody gets injured and they get care. Now, this came about in the early 1900s when medical care and science was a lot more primitive than it is today. And so the types of injuries we were looking at are a lot of orthopedic injuries, breaks. You weren't really aware of brain injuries and different things like that. But what the system was geared to be aligned to was looking at all of those types of injuries. And what evolved was an occupational medicine industry that addressed those things, and in most cases, effectively so. I say in most cases because I remember, actually, even up to recently, a study came out showing we really have no problem with work comp because everybody has access to care. But when you drill down in research like that, which is very important to drill down, what you realize is there's more to that than meets the eye. Because on the one hand, we could say, yes, everybody has access to care. And as Dr. Ali mentioned, in most cases, with a lot of bad injuries, people get better, 80 to 90%. And up until we started some of our research in the early 2000s, you would notice that there was no recognition of what today is being called chronicity. Chronic pain wasn't even on the books. And so when we began working with insurance carriers and the Department of Industrial Relations and Division of Workers' Comp, what we did is we presented a whole series of studies which actually demonstrated that, and again, this was in the early 2000s, that these few cases, the 10 or 20%, were really accounting for 90% of the costs in the working comp system. And how did that come about? And I think that's why it's very important to understand this, because when we talk about SUD or substance use disorders, that's a symptom, right? It's important to understand that injuries cannot just be looked at as symptoms either. Because what happened is that as injuries became more, as we recognized that injuries became more and more complex, the system didn't change. And for the most part hasn't changed. We still on a linear way of addressing injuries, seeing what fails and then going on to the next level. And we're treating diagnoses. Historically, we even when it comes to, say, spine surgeries, we don't operate on what we see in the patient. We're operating on an MRI. And so what became more and more important to understand, and this is where I think that risk managers are the new heroes, the new innovators, because we're seeing some extraordinary innovation that's coming from risk managers. And if you want later on, we could speak about that. But I think the most important thing for us to learn is, number one, these are man-made injuries because we create the injuries and we're not providing the appropriate care. And my last point right now is, what does appropriate care mean? Somebody gets injured and they could go into a initial level of care. And in many instances, that's really appropriate. If it doesn't work, then they go to a higher level of care, right? But the important thing is not chasing the diagnosis. You have to understand what is the dynamic going on and matching treatment to injury. If you do that, you're able to systematically reverse the epidemics we have in work comp. And to match it, the way you do it is you think in terms of the architecture of care. An architecture of care, if we want to just list it, goes unimodal. Like if I would need to see a gastroenterologist, or a pulmonologist or an orthopedic surgeon, I would go, or a psychologist, I would go see an individual. If I needed to see two individuals, it would go unimodal care to multimodal care. Now I'm seeing different people. We're all accustomed to. If I need more than that, I would go into multidisciplinary care. But if those don't work, because they're not coordinated, everybody's working in a silo for the most part. A higher level of care is where there is interaction among the clinicians. I'm almost done with this, by the way. And that is what we call biopsychosocial multidisciplinary care, but it's still fragmented. If we're seeing patients aren't getting better, instead of just taking them through levels that don't work, you want to immediately get them to the appropriate level of care. And so you have transdisciplinary care, which actually has all the specialists, all the different people thinking like one nervous system. They're all seeing the patient together, discussing the patient together, working forward, right? And then you have the highest level of care, the highest architecture of care, which is called the transdisciplinary biopsychosocial therapeutic community, which permits you to take the most serious cases, what we call the real chronic cases, those who never end up going back to work, you immerse that in the environment and you see how their trajectory is systematically reversible. And what Dr. Ali is going to be about is, historically in comp, we speak about these chronic cases. That's a mindset that has to change, because chronic to most people means forever. And that's the worst label we could give anybody. We need to, in terms of persistent, you have persistent pain, you have persistent PTSD, you have persistent symptoms of brain injury, because right architecture of care, it's at that point that you're able to reverse that. And when you look at I'll use San Diego as an example because they're the 7th, right, largest city in San Diego. And they partnered with Institutes of Health, as did the largest healthcare system here. And working together, Dr. Ali will be able to speak about the extent to which we're able to reverse systematically these conditions that our legacy thinking has told us are not reversible.
So I want to unpack that. That was a lot. Thank you. But I want to unpack that a little bit for our listeners. So I want to first talk about what you referred to a few times, Dr. Anbar, as some of the chronic conditions that you mentioned are man-made conditions, that we're creating these injuries. So I'm going to take a pass at what I think you mean by that, and you correct me if you think I'm wrong. But what you're saying with that, and this is what we're going to talk about today, is that we often are creating layers of complexity because, as you mentioned, we're chasing a diagnosis in workers' compensation. What we mean by that is we're trying to match the diagnosis with the injury, the work injury, then making sure that that's connected, right? Am I right so far?
Yeah.
So what we should be doing...
I could give you an example as you go along. It's because I thought Rafael and I and Dr. Ali and you were going to be sipping on Cuban coffee. That's the only reason we're fast. But yeah, so what happens very much in work comp, it happens outside of medicine. To go with your first example is, let's say you have chronic pain in your back. So you go to see a doctor, an orthopedist. Typically it's an orthopedic surgeon. And what they try to do is they try to correlate the pain to some pathology in your back. They're looking for a pain generator, right? And once they find a pain generator, what they're going to do is look at how they're going to do an intervention, surgically, chemically, however. But the reality is, when we look at over 50 years of studies of back pain, I just want to shed a little light, because your point is so important on back pain. And some of these studies were great, where they took 100 adults off the street with no back pain, and they ran them through MRIs, and they saw close to half of them had real severe pathology in their spine. Never knew it, right? And when you take some, and by the way, that's like a normal spine. Normal spines aren't perfect, but they work just fine. So then you get an injury. You don't get the appropriate understanding for that injury. And so now you're taking a look at, okay, this person has this pathology in their spine. We're going to go in and we're going to fix it. Now, there is a place for surgery. 100% you want to go to a good surgeon. The problem we've seen over the past 30 years is when you just stick to that persistent pain, you're looking for the pain generator, you see, aha, I saw it in the MRI, we're going to do the surgery. 70% of those surgeries, the patients are either the same or worse after that surgery. So that goes to your point, Yvonne, about correlating the symptom to some pathology in the body. And that's the same case, by the way, with brain injury. We call brain injury the invisible epidemic, because in most brain injury, you cannot see on the imaging the brain injury. It affects many other areas. which we could diagnose really well and treat. Unfortunately, we're still stuck on using a very simplistic model of diagnosis versus the wealth and sophistication we have to diagnose and to appropriately treat.
Thank you. So I'm gonna invite Dr. Ali into the conversation to continue to unpack a little what you said earlier. So as we mentioned, let's stay focused on treating PTSD, complex PTSD, because I think that is a really good example to demonstrate what we wanted to kind of hone in on of this nuance of discussing substance use and workers' compensation, which is quite rare. So Dr. Ali, tell us some of the ways that we should understand that substance use is related to an industrial injury, because it's not really something we would say is. But what are some of the examples of how we know substance use is related to, say, for example, PTSD?
It's a great question. And so I can elaborate on that just from some of the training, but also some of the direct experience that we've seen with patients. And so a lot of times we see in the workers' comp system, particularly in the PTSD IOP, is that the workplace event can directly contribute to substance misuse in the first place. As Dr. Anbar alluded to earlier, substance use is the symptom of another disorder or something else that is underlying. And so if you think about a traumatic event, for example, so we work with a lot of first responders. This is just an easier example to pick out. A line of duty death, critical incident, a violent encounter of some sort can lead to acute stress or PTSD if it's been there, those symptoms longer than a month. And then the injured worker can begin to use substances to then cope, right? And so we want to be careful about the nature of the use. Even if predating the injury, people did use substances recreationally, right? Non-problematic, so to speak, right? The workplace or that work event might intensify that pattern of use. So what was once considered casual or recreational use is now considered more problematic, can lead to more dependency, and even addiction if not addressed. And so in workers' comp, we call that the aggravation, right, of some pre-existing condition, and that is now linked to it directly industrial related. The other piece of this, of how substance use we see can be work related, is that for certain groups, thinking of first responders again specifically, substance use is oftentimes normalized as something as like a quote unquote stress relief or something we just do after a hard shift. And that is a way to help manage sleep or hyperarousal. But the problem is that now becomes integrated and intermixed with the issue with the trauma itself. It's wrapped up in the traumatic injuries itself. And so those are some key examples and ways that we've seen it not being separate. We don't want to look at substance use as just something personal or non-industrial. It actually becomes a fabric tied to the underlying concerns that were there. And it becomes a crutch for a lot of people to use. And so that's in the context of some of the PTSD. I hope that answers some of the question.
It does. So just to sort of recap, so we see substance use oftentimes is a way for folks to self-regulate. They're experiencing chronic pain. As you mentioned, they might have had some minor use prior to the injury, but after the injury, they might have elevated levels of chronic pain. So they're using it to deal with their pain. Is that right?
Correct. So whether it's traumatic injury and then for chronic pain too, right? So people will self-medicate when that pain or that trauma is not adequately controlled. And so you see these things with chronic pain. And Dr. Anbar, I'm happy to pass it over to you. Even prescribed medications can then become a part of the problem. That's the dependency on it.
Yeah, and those are gateway issues, putting people on a lot of these medications, whether it's either to sleep or for pain, and then they end up, drinking an awful lot, and that causes a lot of problems. The anxiety, we society that suffers from more and more anxiety and depression, and some socially acceptable ways of dealing with that are getting together and drinking. I think one of the biggest problems in terms of why we have an epidemic of substance use, apart from the social media and the instant tsunami of constant distressing information, is we also learned it. We learned it in our industries, you know. Some folks after work, depending on their work, they go out for some beers. And if there's stress at home, you know, you're going to have more beers or what have you. I think one of the things that's contributed to the substance abuse epidemic is that it really started in the 70s when a lot of the industries opened up homes across the country selling detox services. So you would go in there and you would attend groups. Probably the strongest thing that came out of the 70s was an awareness of Alcoholics Anonymous. So for those people who were able to stick with Alcoholics Anonymous, it was a lifesaver. But it's a maintenance system. What we see is that in most instances, in the type of damaging substance abuse or alcohol use within the work comp system, that alcohol is actually functioning as a barrier to their effective treatment. So even though in so many instances the alcohol or the drugs are not industrial related, the underlying mechanisms are industrial related. If you get the right treatment for substance abuse, then you're able to remove that barrier and focus on the underlying mechanisms that are contributing to that symptom. So the problem is, once we began speaking about, for social reasons and political reasons, that substance abuse or alcoholism is an illness, is a physical illness in and of itself and has to be treated, I think we did a tremendous disservice to our society, because you begin focusing on the symptom and you're not addressing the underlying mechanism that systematically is able to reverse that. So for example, research we've done for years with the city of San Diego, because we get patients from all over the state in California. We get a lot of first responders, as Dr. Ali mentioned. And one of the presenting problems, the reason why we're sent by municipalities or major employers patients, is because the first thing they see is the substance use or the alcohol, right? And then there's the issue, well, yeah, but that's not an industrial thing, all right? That's the presenting problem. So you end up going into a alcohol or substance abuse or detox setting, and it's a revolving door. You go in, you could go in for 30 days, 60, 90, 120. You come out, you end up crashing all the time, because these places, they're really not designed to address the underlying mechanisms, the psychoneuroimmunological components of it, the inflammation, the trauma, the underlying trauma, mechanisms of trauma, which are contributing to all of the symptoms. And you would have to be a masochist not to try to drown those things out with alcohol or drugs. Who can take such horrific pain and suffering? So if we go back to SUD, the whole idea is to focus on the underlying mechanisms. Don't get lost on just, looking at the substance abuse, because you're going to just continue with that high recidivism rate. You're able, even the most complex PTSD cases, which Dr. Ali runs a unit, the institute, the First Responder Institute for complex PTSD. Up until we started that institute about 5 years ago, you would have first responders medically retiring, most never going back to work. The research San Diego and other areas has now, working with the Institute, is there's this is complex PTSD and alcoholism or drug abuse. There is a 94% recovery rate. You no longer have the diagnosis, but a 94% return to work rate. And so the important thing is not to follow the fads. We have a tendency of following fads. We have a tendency of structuring our work comp system based on controlling access to care. You know, in work comp, there's two economic models. One model controlling costs is to control who has access to care, and that's the prevalent one. The other model is ensuring you get architecture of care as quickly as possible, even if it's a future medical thing. If you re-enter the schematic and get the right architecture of care, you're able to reverse that. So here's the last point. Just think of the data that comes out of San Diego and what Dr. Ali works on. You have somebody suffering from disabling pain, all right? Or a disabling brain injury or disabling PTSD. They're in and out of treatments, unimodal treatments, multimodal treatments, what have you, day in, day out. It goes on for years and years and years. I know that I think in, the average, probably 80% of the people that are referred to us resolve in a modal level. But virtually everybody who needs to go into a higher tier of care, they all reach MMI by the end of treatment. And in California, you have this thing called PNS, where they're permanent stationary, so the case could be closed. But just think of this. If people would get, wherever they go in the country, as long as they're getting the right, I'm not advocating institutes of health. What I am advocating is the right architecture of care so that the MPN or the carrier, the employer, actually goes and vets their providers to make sure they understand the architectures of care. They have their data to show how they're able to systematically reverse this. And what you're going to see is if you have an average of a case where somebody is struggling for 4 years, if they would have gotten the treatment up front, later, you would have compressed that whole case to 12 weeks, 12, 14 weeks. So instead of paying out all the legal fees, and by the way, you avoid a lot of legal fees this way, because by not giving appropriate care, then you're creating feelings of organizational betrayal and moral injury and bad feelings. You don't feel like your employer is backing you up and protecting you. And, let's face it, our employees are our most valuable asset.
So Rafael, we've heard a lot. I mean, I think Dr. Anbar has done a really masterful job of laying out some of the complexities in our industry, while also I will say thank you so much, Dr. Anbar, for sharing your description of the workers' compensation system. I think it was beautiful. And those of us that have been in the system a long time know about the grand bargain, and we're teaching the younger folks about that as well. But Rafael, I want you to poke holes. Why in the world should somebody be considering paying for treatment for substance use in workers' compensation?
Is there, from a medical perspective, a method, a way to treat that original accident, traumatic event that's causing the physical pain, because that belongs to the employer carrier, versus the treatment of these behavioral components, the substance abuse, the alcohol, the drugs, right? The things that may be, that the claimant has himself, for whatever reason, chosen to go through. Now, doctor, you also added the prescribed medication, which oftentimes we see as a component of. Is there a way to treat these things separately and apart from each other, or must they always be treated, together?
So when we're talking about the injury itself, I like to use the model of care that Dr. Anbar just spoke about, that that we use and that we want to see more involved within the workers' comp space. And that is what we call the biopsychosocial transdisciplinary approach to care. And what that is it's looking at everything related to the individual's biological injury, but not just the biological injury. What is their social support? And what is the way they psychologically adapt? What's their resilience? What are the thoughts and behaviors and emotions related to how they're processing with the injury? And so when you look at the person in totality in that way, you're no longer pigeonholing them in just one area of how to recover. Because, for example, if it's a chronic pain injury and you have minimal social support and the thoughts about the pain is that it's never going to go away, very likely your symptoms are going to continue to be exacerbated and they're going to remain, and it's going to feel like this is truly chronic. But when you have all systems in place operating at the same time, as Dr. Anbar alluded to, nothing acting in silos, all of this is brought to the surface. The ability to respond and recover becomes extremely more effective. And so that goes not just for pain, but also for trauma itself. When you are experiencing complex trauma, complex PTSD, what are all the symptoms in place that you're addressing with? And so for PTSD, for example, I won't go too far off here, but it's what are we doing for evidence-based care? And evidence-based care is essentially finding a method of treatment that is reproducible. What's reproducible for one person is effective for somebody else. And so the more evidence-based treatment you use, the more likely you're going to find ways that that's going to be more successful for the next person struggling with the same event or a similar event. And so with all those systems in place, you're then able to find the common method of what are the areas needed to help them truly adapt and get established for appropriate care.
When we look, say, at back injuries, such a huge problem, right? Or any physical injuries for that matter. After about 90 days, the tissue damage should be healed, right? The problem is after those 90 days and you see that the tissue has healed, why is the person in such pain? And then why do they begin developing, the sleep problems or hypoglycemia or different things like that? And it's because the tissue damage is fine, but what happened is because the symptoms were allowed to persist so long, they began changing the nervous system and the actual shape of the brain. We see how the brain shapes. The good news is it could be brought back, right? And that's why you need to attack everything as quickly as possible as one part of the nervous system. That's how you reverse it. And by the way, that's how you, I want to speak a little bit about litigation. When individuals feel like they're being taken care of appropriately, you reduce litigation. You systematically are reversing the overall cost of the claim because you're accelerating the healing process. What you can't do is try to just do the orthopedic thing, because if it's after 90 days and they're still suffering from pain, what happens? They're sent to pain management. What pain management? Now they're going to start getting medications. They're going to get anti-inflammatories. The truth of the matter is, inflammation at this point, even if it's a PTSD, is throughout your body. Clinical nutrition is much more effective in reducing inflammation throughout your body, so you're able to gain function. And my last point, because it's so important what you said, is instead of chasing symptoms, I'm in constant pain, I can't function, I can't think, you have to focus on function, not on the symptom. So if you could get me now to start washing my dishes, to start lifting up things, my others, and remember, it's persistent pain, my other symptoms are going to start coming down. But what that takes is intensive work. It takes working with a combined psychologist and fitness trainer or Feldenkrais person. It takes pulling in a neurologist to show them that in their brain, there is no pathology. It's a nervous system thing. So that's why we refer to all of this. The fastest way of reversing a persistent or, unfortunately, a chronic condition is in a transdisciplinary way. You don't want the neurologist going off and doing their thing, the psychiatrist, the psychologist, the physical therapist. They all have to be working as one mind, and they all have to have the same responsibility to achieve the outcome. And the outcome is making sure that the patient has responsibility for their healing. That's what we call self-management and self-efficacy. At the end of the day, a patient who has fallen into what we call this biopsychosocial vortex, this chronicity, has to become an expert in understanding how this is reversible. And so they become part of the team. That is the fastest way to heal the trajectory and avoid this epidemic. Because when we look at the epidemic of brain injuries, again, in comp and in, whether it's chronic pain and the associated things, we've created them by not following evidence-based architecture of care. What we continue doing is this kind of primitive stuff. And that's why I'm saying that risk manager claims, the of risk managers, they're the heroes. They're implementing this stuff. And we see it across San Diego and in other municipalities and agencies and employers that are doing it. They're turning the whole system around. And I think that's always what's driven a lot of us, the excitement to know that this stuff is reversible, and you see the lives you save, and you see the extent to which risk, I'm looking at Dr. Ali, most risk and police and fire chiefs don't work together. It's unbelievable that they don't. You get these people to work together, you're accelerating the healing process. You're using the innovation of introducing the most effective systems that are being driven by the risk managers. You're training training claims people to understand the populations they're dealing with is a real game changer. So you have claims folks that should be trained on the general population, different claims folks that need to specialize with law enforcement, claims people who specialize in fire and rescue, because the cultures are so radically different and the way it impacts the nervous system and the families and so on. But the thing not to be afraid of, and this is the last point I'll make. So I was a consultant years ago to some very creative major insurance carriers. And so we demonstrated, in the early 20s, how you're able to reverse these things. So this stuff was being reversed outside of comp. And two of the VPs said together, can we stay away? Now, this is in 2002. Can we stay away from using the term biopsychosocial? It sounds too expensive. It sounds like there's psychology in it, okay? And that has been an ongoing legacy, because even when we look at the most complex psychological injuries, like complex PTSD, those are 100% reversible. And I think that's the message that we all have to take away. And if you look at cities like San Diego, where they're systematically reversing all their PTSD on an outpatient basis. Inpatient, you need very little inpatient even to treat SUD. Most SUD should just be treated as part of the underlying and not as a separate program.
So we're going to have to do a rapid fire. Rafael, you get one last question.
We really need a little cafecito, a little café con leche. Yeah, I like it. Is the answer then bringing on your subspecialties to the treating table from the very onset of this accident, so as to make sure that that physical treatment and these ongoing components of the equation are always taken a look at and are always walking simultaneous instead of the silos that you've indicated already?
Absolutely. And they should all be working as one unit, same language. Even if you have a clinical nutritionist, they need to be doing the same thing the neurologist is doing, the psychiatrist, the physical therapist, because they're looking at all those details and they're having to take it forward, because you're looking to close the claim as quickly as possible, because that's the healthiest thing for the patient as well. That's why we refer to it, it's got to be transdisciplinary, not multidisciplinary. When it's needed, transdisciplinary. One fabric, one nervous system is the way you need to think about this. And vet your providers. Wherever you're going in the country, vet your providers, physically vet them, spend time with them. Make sure the people you're choosing can achieve this, because it's not a large number of providers you need. Most of your providers, what needs to be done, the 80%. It's just for that 20%. You need to make sure that you're vetting providers who can deliver this level of outcome.
Okay, so I'm going to ask Dr. Ali a quick question to wrap it up, and then we'll end it there. So, Dr. Ali, we talked about a lot today. This has been a very fascinating conversation, so thank you both for spending time with us today. But let's recap some of the barriers and some of the other issues. Again, I want to kind of make it crystal clear for those work comp professionals that are listening to understand why we want them to be thinking about some of the things we talked about today, particularly in relationship to substance use.
Sure. It's a great question, Yvonne. So I'll make this brief because I know we're a little bit limited on time. And so when we notice substance use can be a barrier, and there's different ways that it can present. And so it's really important to have a grasp of this. And I'm going to explain some of the ways that it shows up. And then I'm going to talk about why this is helpful in the workers' comp system. Number one is that if SUD is not addressed, substance use is not addressed, it will reduce treatment engagement and reliability of having healthy outcomes. And the way that looks like is missed appointments, poor therapy retention, difficulty complying with any medication plans, and even inaccurate reporting of symptoms. It also interferes with any physical rehabilitation. We see slower healing process, higher pain levels reported, poor physical therapy participation, poor reliance, not just in the clinic, but at home doing the homework. It also complicates mental health treatment, right? So if they're doing evidence-based psychotherapies, that also becomes a barrier because that requires homework and it requires sustainability and stability to do the work. It also can increase safety concerns, higher risks of overdose if people do have a true tolerance on it. Withdrawal symptoms can present, and then detoxification would be needed as well. And so there's the barriers if not addressed. And I say all this because when we talk about why this is important in the worker comp space, if you ignore substance use, and although it is a symptom of an underlying diagnosis that we're talking about, it can delay recovery. It will increase the costs. It will amplify the suffering of the patient, and it complicates every single part of the claim. And so just to make this, and I'll wrap it up here at the very end, we want to know that substance use is not simply a personal issue, but it's really triggered or exacerbated by the industrial event itself. It's intertwined with comorbidities like PTSD, chronic pain, as we call our pain, or even depression. And we oftentimes see it develop after trauma or injury as a means of self-coping, to self-medicate, and it will be a major barrier to recovery if not addressed early. I'll close with that.
Thank you, Dr. Ali. Dr. Anbar, any closing comments on what we talked about?
Just to say the good news is not to be cynical, not to be jaded by these what are typically called chronic conditions, because they are reversible. You can replicate it, And the more you vet places and identify places across the country, wherever you are, the more exciting you're going to experience the fact that you're turning around your work comp system, improving outcomes, decreasing costs, and saving lives.
Thank you. And I will say, before I forget to say it, we just did a webinar on substance use, when substance use is an industrial. So we did talk a lot more about some of the other components we touched on today. So if you're interested, go check that out. I'll drop the link in our show notes for this. But Rafael, any closing thoughts from your end?
I always appreciate it. I always learn a great deal. So thank you both very, very much. Very grateful.
And Yvonne, maybe you put the, I don't know if it's something you could do, but if you could put the link for Public Risk Magazine for people who are interested in knowing more about this. The cover story addresses this, particularly in terms of how important the risk managers are in being the heroes of the system.
I absolutely will. So we always like to wrap up on a fun note. So I know Dr. Anbar likes to joke with me about bringing Panama bananas to him when I see him. And then whenever he sees Rafael, he talks about Cuban coffee. So I wanted to kind of share, I want to share something really fun that people may not know about Dr. Anbar and Dr. Ali. There's something I know that Dr. Ali is up to that's always incredibly motivating and inspiring. Are you going to participate in the marathon this year, Dr. Ali?
So I had my PR, my personal record last year in Houston. And so I was very, very satisfied with that. And I tried it 3 more times after that race, and I wasn't as close. And so I have something lined up for the fall, but no Boston this year. My hope is New York in the fall. That's the goal.
Okay. So yeah, Dr. Ali shares with those of us at IOH incredible photos of his marathon activities. It's really inspiring. Dr. Anbar, how about you? What's something fun that people might not know about you?
That I really try to keep up with Dr. Ali, but I need a bicycle.
That's a good one.
I love it. I love it.
All right. So we're going to say goodbye, but I don't want you to go anywhere. So you all stay put. But thank you so much for spending time with us today. This was a really robust conversation. And Rafael and I always love to say, until we see you next time, hasta luego.
Hasta luego.
Hasta luego.
Hey, Rafael, such a good episode. What did you think?
I love it. But I love all of our episodes, Yvonne.
Me too. Me too. So listeners, thank you so much. We really appreciate hearing from you and seeing you when we're out and about traveling to different conferences around the country. If you're new to the podcast and want to know how to connect with Rafael or myself, you can find us both on LinkedIn. We each have a LinkedIn page under our names. And then we have a dedicated page for Deconstructing Comp podcast as well. Love to hear from you there. Ralph, where else can folks find us?
Well, Yvonne, and this is thanks to your incredible leadership. We have a website. It's beautiful, and you can keep up with all of the episodes and make sure that you can listen on them. It's really easy to stroll through. And as of last year, we've got a YouTube channel. So yes, you can see us shenanigans and all have fun together. You can listen in and watch us through all of our episodes.
And I've got some things up my sleeve. We're going to have some more fun with YouTube a little later this year. So get ready for that. It is a fun way to engage with the episodes in a different way. And a newer thing that we're doing is to find us on Substack. It's a new platform. This is how we're pushing out our newsletter. This is how we also push out and share our podcast there. But it's a great new platform to find content that you're interested in and engage with it. It's really fun. So check us out on Substack and subscribe to us there. any podcast platform, you can always find us. Like Rafael said, it's really easy to go to our website. Got all the episodes listed there. You can just click and listen to them there, or find the podcast platform that you like to use, Apple, Google, Spotify, wherever you like to listen to us. Like us, rate us, please share us with your friends. It really helps to expand our reach. And sign up for our Comp Deconstructed newsletter. You can do that on the website. So it's really fun. And Rafael and I are having a lot of fun producing that every month. Comes out monthly. And we take turns taking a deeper dive into one topic. And then we've got a lot of other really cool stuff there. So until next time, thank you so much for joining us. What do we say, Rafael?
Hasta luego.
Hasta luego.